about 69 participants who logged in. We have received approximately 270 logins. Registrations from as many as 8 Indian states, and we've got a couple of countries, Zimbabwe and United Arab Emirates too, who've logged in. So that's making it rather, a regional or maybe an international event, really speaking. So a very warm welcome to Dr. Casey. Just give us a couple of minutes before we launch this lecture series formally. Thank you so much. Thank you for your patience. Reaching out to Dr. Sister Lizanne. Could you just speak in your mic, sister?
Yes, sir. Yeah. Am I audible?
Thank you, sister. Thank you. Yes,
yes, sir. Yes, sir.
Good afternoon, everybody. Just before we begin, I would just like to inform all the participants that I will be muting all participants except those who will be presenting, and requesting all participants to not put on their cameras as to avoid any distractions to the speakers. Thank you.
Good afternoon, Dr. Shailesh. Very warm welcome to you.
Good afternoon.
Right, Karen, I think it's exactly 3 in our clock, and I think we should launch the proceedings of this time.
Yes, sir. Let me just show my view. Am I audible to everybody?
Yes.
Yes. So a very good afternoon to all the delegates who are present here. I am Ms. Karen Braganza, Assistant Professor in the Department of Zoology, Carmel College of Arts, Science and Commerce for Women, Nuven, Goa. We are delighted to see such an enthusiastic response for this lecture series from students, members of society, academicians, and medical practitioners as well. Carmel College is a premier institute of higher education for women in Goa and across the nation. We not only educate our students in various disciplines, but also impart values and skills that give them an advantage as they integrate into society. At Carmel College, we take upon our shoulders the responsibility of sensitizing our stakeholders to critical issues of the environment and health, thus molding responsible and aware citizens. As a community outreach initiative, the Department of Zoology is addressing the issue of infertility, which affects a sizable population of both men and women across the world. Infertility not only affects reproductive health, but also has various social, psychological, economic, and physical implications. The stigma surrounding infertility can cause emotional stress, depression, anxiety, and low self-esteem. Education and awareness to address understanding of the prevalence and determinants of fertility and infertility are very, very important. Through this lecture series, we hope to disseminate information about infertility and to inform the audience about the alternatives that modern medicine can provide us to combat this issue. At this moment, I would like to acknowledge the presence of the head of our institute, Dr. Sister Maria Lizanne AC, who is also a faculty at the Department of Zoology. I request Sister Lizanne to kindly address the delegates. Sister Lizanne, over to you.
Thank you, Karen. I feel privileged and honored to extend a cordial and loving welcome to all of you this afternoon for the virtual lecture series on infertility, an embryologist's perspective in assisted reproductive technologies. A special welcome to Dr. Kesri Avari, consultant embryologist in AERT Mumbai, and also to Dr. Sailesh Kamath. It's a joy and satisfaction to see so many of you registering for this lecture. At the outset, I must congratulate the Department of Zoology for choosing a very appropriate topic for this lecture series with the support from Panaji ONG Society. As many know, that Carmel College of Arts, Science and Commerce was started for young women in Goa way back in 1964, and now it also caters to young men through the postgraduate programs. Knowing about fertility and infertility as a young adult is absolutely important. Department of Zoology, within these 2.5 months, have organized a number of webinars, international as well as national, with topics relevant to the present times and situations, as well as those beneficial to the humanity. One of such is today's lecture. The number of participants always crossing hundreds, and now this lecture series as an outreach program will again benefit many, and I'm sure of it. I'm really proud of the department to which I belong to, for I know there's a lot more to follow. To say a few words about Carmel College, it is nestled at the foothills of Neway, which is a serene, untainted, and picturesque village. The college provides a very conducive and safe learning environment in higher education, especially for young women and men in the state and beyond. It grooms feminist leadership as well as instills an environmental friendly ethos in the students. As one enters the gates of Carmel College, one is greeted by a verdant ambience which complements receptivity for learning. The spacious campus instantly makes one feel relaxed and rejuvenated. As I end, I can assure all the participants that this lecture series will definitely be very interesting, educative, enriching, and enlightening to all of you, with the inputs from an eminent and experienced embryologist, Dr. Kirsi Avari. While I wish you all the best, I take this opportunity to thank Dr. Avari for accepting to be the resource person for this virtual lecture series. I also extend my thanks to all the participants and special thanks to Dr. Borkar and all the faculty of the Department of Zoology. Thank you and God bless.
Thank you, sister.
Thank you, sister. As we know that this lecture series is being supported by the Panaji Obstetrics and Gynecological Society. And we have with us the president of this association, Dr. Sailesh Kamath. Dr. Kamath is a well-known and accomplished gynecologist in the state of Goa. I now invite Dr. Kamath to kindly share with us his opening remarks. Over to you, Dr. Kamath.
Thank you, Karen. Respected faculty of today's webinar, Dr. Kesri Avari, Principal Dr. Sister Maria, HOD Dr. Manoj Borkar, other faculty of the Zoology Department, and all the delegates. A warm welcome on behalf of Panaji Obstetrics and Gynecology.
Apologies, Dr. Kamath, we are not able to hear you clearly. If you could be a little louder, please.
Okay, I think maybe.
Sorry for the interruption, sir. Apologies.
No, it's okay. It's better now. Yeah, okay. I welcome you all on behalf of Panaji Obstetrics and Gynecological Society. To begin with, I must congratulate Department of Zoology, Carmel College for such a wonderful community outreach initiative, because it is the spread of knowledge that and only that can be the powerful buster. Especially about the field of infertility. There are so many myths coming out of tradition, religious beliefs, other social beliefs, and if nothing else, then the social media, what we commonly call as WhatsApp University. There are so many myths coming out of there, and only way to bust all of them is scientific information, and that webinars is a very good source. And today's attendance proves that there are many years to hear. We need many more resource persons like Dr. Kersey to pass on the knowledge. Panaji Obstetrics and Gynecological Society is an association of gynecologists coming from private as well as public government services spread all over Goa.
Introduction.
Our main aim and motive is spread of knowledge. May it be amongst our members about the recent developments in gynecology or subjects like this to the general public. So when Department of Zoology approached me, I said, wonderful, you should go ahead. And not only Department of Zoology, Carmel College, but any other institution which want to do these wonderful jobs of community outreach initiatives, Panaji Obstetrics Gynaec promises you that any such initiative will be always there to help you out. Maybe it's a resource person, maybe any booklets, knowledge, or anything you want from us will be willing. There are many such topics which you can take in future, say menstrual hygiene, adolescent health, cancer prevention, anything, and we'll be there with you to support in any such endeavors which you want to undertake. Once again, I congratulate you. I thank Dr. Kersey for taking time out of your busy practice, and over next 3 days, you are going to enlighten us on various issues of infertility. Thank you very much. I wish this webinar a success, and thank you once again. Thank you all.
Thank you, Dr. Kamath, and for your opening remarks, enlightening us about what are the issues we can see, and also for extending your support to any of our future endeavors that we may undergo for. Thank you so much, Doctor.
Sure.
I now invite the convener of this lecture series and the head, Department of Zoology, Dr. Manoj Borkar, to welcome the delegates. Dr. Borkar is a senior academician who is known for his work in conservation biology and biodiversity, but it may interest you to know that he has done his doctoral research in reproductive endocrinology from the prestigious Institute of Science, Mumbai. So I hand it over to you, Dr. Borkar.
Thank you, Karen, and a very, very good afternoon and a warm welcome to everybody who's logged in on this Sunday afternoon, sacrificing, I should say, your rightful siesta. But trust me, this Sunday shall be a knowledge Sunday for everybody here on a very important topic, as the previous speakers and the office bearer of the Obstetricians and Gynecology Forum has rightly said. It's an important topic of relevance to all of us who've surely come across in our lives somebody or the other who's probably a part of our families or part of our friend circle, who's either in need of support, counseling, a way forward to address an extremely sensitive issue of infertility, which again is a taboo for any kind of discussion. Infertility is often viewed as a curse, probably a carry forward of our previous life, or maybe fate. Notwithstanding the progress in the area of assisted reproductive technology, the affected often choose to try magical remedies with little respite. And then they stay with the stigma and live a life of hopelessness forever. Often a simple and a right advice from the right people could be a turning point in addressing this stalemate. Right information with right action by the right people is the answer to this puzzle of infertility. Often it is the woman, unfortunately, who bears the brunt of this infertile status and faces a familial and a social ostracization. It is exactly here that as an institute of higher learning for women, Carmel College takes upon its shoulders the responsibility to intervene and offer to the community an outreach program to bring to the needy critical information on infertility and ART. At Kamal College for Women, Goa, we've always believed in our responsibility towards the community beyond academics, and we strive very hard to address a lot of critical issues through our knowledge events by bringing renowned experts across the nation and beyond to interact with the community, who we regard as our most important stakeholder. The strength of our success, of course, hand-holding with our knowledge partners. Today's webinar is one such attempt to bridge the gap in understanding of infertility and the interventions to treat the same. As our expert, we have with us a renowned consulting embryologist from Mumbai, in Dr. Kirsi Avari, who I shall introduce to all of you a little later, but we also gratefully acknowledge the support received from the Panaji Obstetrics and Gynecological Society and to their president, Dr. Shailesh Kamath, who willingly agreed to associate with this event and gave us his precious time. I welcome him and all his fraternity colleagues who've joined us in this lecture series. To all my academic colleagues and students from various institutions from Goa and beyond, a very warm welcome, of course, and appreciation for your interest and time. Needless to say, our consistent programs reflect an unconditional support from our institutional head, Dr. Sister Maria Lizanne, who's also my faculty colleague, and of course the management, for which as a unit head, I remain grateful. Last but not least, but for the eloquent and knowledgeable Dr. Kirsi Avari and his willingness to spare his time for 3 long days, this virtual lecture series would have been a distant dream. I thank and I welcome him for his kindness. Once again, a very warm welcome to all of you, and have an intellectually stimulating afternoon with our expert, Dr. Kirsi Meherji Avari. Back to you, Karen. Karen, are you there?
Yes, sir, I'm here.
Right. Do I also introduce Dr. Kirsi if I have a little time?
Yes, sir, you go ahead.
Right. So to take this further, allow me to kind of reveal my acquaintance with Dr. Avari. You know, in life, we all need mentors and a guiding light, I would say, to show us the path of progression when there is darkness all over. And then when we prosper in such erudite, selfless company, we must recognize their contribution in a little success that we have achieved in our lives. Just to quote Shakespeare, they say, he said very famously, sharper than a serpent's fang is an ungrateful child, and I certainly don't want to be one. So as I introduce today's invited speaker and consulting embryologist, Dr. Kirsi Meherji Avari, I am reminded of our 36 long years of familiarity and friendship. I first met Dr. Kirsi Avari when I joined the prestigious Institute of Science way back in 1985. And then all along, he has been my friend, philosopher, and guide, and needless to say, my biggest benefactor in my life. From guiding me for my doctoral research, co-authoring as many as 5 research papers on pituitary ultrastructure altered by various drug regimes in peer-reviewed research journals of repute, taking me along for Young Scientist Conference to Central Drug Research Institute, Lucknow, way back in the 90s, and for the Society for Comparative Endocrinology and Reproductive Biology conferences to Surat, where we together made a lot of research presentations, to editing my doctoral thesis, and not to forget, offering me a very warm reception and stay at his home for over a year during critical times in my student life when I had nowhere else to go. Dr. Kirsi has done it all with a smile and affection. I must place it on record that it is this gentleman who has honed my English communication skills as well. Not just to me, but for several generations of students, Dr. Avari has been the lighthouse in rough seas of research. I'm a huge admirer of this gentleman of science, and I wouldn't be wrong if I say a quintessential Parsi benefactor of many like me, and I rejoice in his career progression and accomplishments as an embryologist of repute today. Just to acquaint you with Dr. Kirsi's accomplishments and professional competence, allow me to highlight a few important things from his exhaustive professional biodata. Dr. Kirsi Meherji Avari is presently a consulting and practicing human embryologist, program director, and application support specialist, who, as he loves to say, works for his, use his skills, expertise, and in-depth knowledge for betterment of unfortunate childless couples within and beyond the country. Just to highlight a few interesting things about Dr. Awari, from the school to his tertiary qualification, he's always been a topper, excelled in academics. He's done his postdoctoral studies in clinical andrology, seminology, infertility, and of course, the theme of today's lecture series, assisted reproductive technologies and application support in ART. He holds a doctorate in science in mammalian reproductive endocrinology from University of Bombay. Dr. Awadi has worked with a lot of anti-fertility drugs. That's quite a paradox. Anti-fertility drugs like depomedroxyprogesterone acetate and testosterone enanthate, and sought to investigate the effect of this on the pituitary ultrastructure and the male reproductive tract of mammalian experimental models. He has been a recipient of the Lady Tata Memorial Trust. He has had the Golden Jubilee Scholarship of the prestigious Institute of Science, Mumbai. He's a visiting embryologist to a number of hospitals and laboratories, not only nationally, but also internationally in parts of Africa, Nepal, Sri Lanka, and many parts of Indian Ocean Rim countries. He offers ART and application support expertise to various IF centers in India. He's been a visiting faculty at the PG Center in various universities of India, program director for Embryology Academy of Research and Training in Mumbai, which is endorsed by the prestigious Cleveland Clinic, United States of America. He's also endorsed by the Embryology and PhD Academy, United Kingdom. Very interestingly and importantly, he collaborates with Dr. Daniel Franklin of Tegeberg Hospital and University of Stellenbosch, Cape Town, South Africa, and presently doing a sperm study in relation with various environmental parameters and improvising a novel gadget which is to be marketed very soon. He's on a list of consultants of VitroLife as regards to media and gamete necessities and troubleshooting. He's worked with Melbourne, IF, Mumbai as a full-time embryologist. Thereafter, of course, he's had several invitations as an expert from various bodies in India and abroad, to name a few: ISAR, FOGSI, FOXY, with which I think most of the obstetricians and the gynecologists Society of India, I mean the Panji chapter of obstetricians and gynecologists, an affiliate of this, and Fertivision, infertility chapters, and so on and so forth. He has a vast experience in the research field and has completed a number of projects. To name a few, he's been one of the collaborators and a key investigator, monitored release study of Lopressor, of a clinical trial undertaken by the Hindustan Sibagaigi Limited. Similarly, he has been doing a lot of work on dysfunctional uterine bleeding, again co-organized by Hindustan Sibagaigi in collaboration with other like-minded bodies. He has contributed very meaningfully to academics in University of Mumbai. To his credit, he has more than 20 research papers in international journals of repute, mostly focusing on ultrastructure and fertility studies. He has conducted numerous andrology workshops and IUI hands-on training. He has trained quite a few obstetricians, gynecologists, even in Goa, who are into infertility treatment. He has helped establish several ART centers in India and abroad, as I've said. That is a little bit, I mean, I would say that is only a tip of the iceberg, and there's so much more to say. But I'm sure with all this introduction, everybody is very eager to listen to Dr. K.C. Awari. And I would certainly not want to come in between the resource person and all of you, ladies and gentlemen, who've come on this pleasant afternoon to listen to our expert on infertility, which will happen in a series of 3 lectures. To start with, of course, today is the first day, and without any further delay, Karen, maybe you can continue with the proceedings. Thank you so much for giving me this opportunity to speak to everybody. God bless. Have a pleasant afternoon.
Thank you, Dr. Borkar, for introducing our resource person. Without further ado, I think we should start with the technical session. But a note to all the participants, if you have any questions to ask Dr. Awari, please type it in the chat box and they will be addressed at the end of the session. I'll repeat. If you have any questions that you wish to ask Dr. Awari, please type it in the chat box and it will be addressed to him at the end of the session. I hand it over to you now, Dr. Awari. Please, you can go ahead.
Fine. Am I audible? Am I loud and clear?
Yes.
Yeah, I'm clear. Fine. So I share my screen.
Yes, sir. Please do.
Okay, fine. Okay.
Right. If you could
Fine.
slightly enlarge it from 81 to maybe around 90%, that would be still great. If that's possible. If not, it's fine.
I think so. I can't.
Oh, it's fine. It's fine.
I think because I have a full screen over here. Anyway,
not an issue. Please.
Fine. Very warm.
Dr. Awadi, if you
Yes.
could maybe try to put it on a slide share view, is that
Slide
possible?
share view. 1 second. Slide share, I think. 1 second. Huh? Yeah, I think it's this way. This mode you want? Hello?
Yeah, nothing has changed, doctor. That's why.
I don't know. Now it's okay. I am on a full screen mode.
Doctor, right on top, there is something which says animation and slideshow. Could you go there?
Animation and slideshow.
Right on top, where file, home.
I don't know. 1 second. Just. 1 second.
Alternatively, Dr. Kersey, may I give you a smaller, easier solution?
Yes.
Yes.
You just go to the enlargement bar and maybe
Okay.
slightly enlarge it. That's all. That's good enough. That's good enough. That's good enough.
Only this way. This way is okay.
Well, it's okay, but it cuts your slide. If you can just scroll it a bit.
I scroll it a bit.
We get to see what's on top. No. I mean, take it. No. I think that may cut a lot of your matter. I think you should restrict to 90.
90. Okay.
Yes. And I think, yes,
90,
that's perfect.
fine.
I think you could just go ahead, please.
Just I go ahead. Okay,
Yes,
fine.
please. Yes, please.
But that means.
Excuse me, sir.
Yeah, carry on.
Just one suggestion. Just to enlarge it slightly, there is this arrow next to the question mark in the right top corner. I think you could click that.
Now you can see this clear.
No, sir. Actually, it's not showing full screen for us.
Now it's okay.
No, sir.
Andrea,
Yes,
could
sir.
you please slowly repeat your instructions to Dr. Kersey on how to go about with this enlargement?
So I think you can escape the slideshow, and in the top corner, just below the cross, there is an arrow.
Can you see the blue question? Right.
Yes, this one. Yes.
That's perfect.
I think this is a little better.
Yes, doctor, this is better. This is better.
Now?
Yes, please go ahead.
We can go ahead now.
Yeah, fine. Sure. So thank you very much. Very good afternoon to all of you. And immense thanks for your kind introduction. But even before I commence, let me first at the onset thank the Department of Zoology, Carmel College of Arts, Science and Commerce for Women, the Panaji Obstetrics and Gynecological Society, Dr. Sister Maria Lizanne AC, the Principal, Carmel College of Women, Dr. Shailesh Kamath, President, OBGYN Society, Panaji, Ms. Karen Bregenza, who has been with me coordinating all these days. Thank you. Thanks to all the participants who definitely form the backbone of the show. And last but not the least, my friend, philosopher guide, Dr. Manoj Borkar, the HOD, who has been knowing me since last 36 years. And with God's grace and mercies, inshallah, our progression of friendship will still commence down the line. Fine. So why have we selected this topic? Now, it's a little out of the field. And my love for this subject started the way back since I was in BSc. My love for zoology actually forced me. Initially, by peer pressure, I was forced to take some other subject, but my love for zoology literally made me change over from that subject to zoology, much to the astonishment of the others, who, well, maybe this field did not have much scope at that time, the way back in the 80s. And what further enthused me was the way in which I did my thesis and my acquaintation with certain top gynacs with Ciba geigy, with whom I was related as far as my postdoc projects were concerned. So, well, the love literally pulled me. It was like a magnet drawing me closer and closer and closer, till the wife of one of the director of Ciba geigy, who happened to be a top infertility endocrinologist, she said, let's start something. And it was on 21st March, 1991, the day when I saw the first sperm under the microscope. And since then, it has been a steady but sure journey step by step into where I am today. Because in those days, the concept of infertility was not all that bright. It was narrow. It was restricted to certain fields only. And what enthused me or what challenged me was that even today, till today, if you come across a couple whose wedding ceremony you had attended a few months prior, what's the first question we tend to ask them? Any good news? And in the event of us getting no for an answer, we eye each other or our body haptics talk in such a way that as if that person or that couple has created a crime by not parenting themselves in the first 3 or 4 months. It is this taboo, it is this stigma which we have till date is causing a lot of unwarranted psychological, physical, financial, and emotional trauma on the poor childless couples and dragging them into a state of despair, a state of helplessness. So, well, later than never, infertility also started jumping up, galloping up, much to the advantage of these poor, helpless, childless couples. Infertility is increasing day by day. And most challenging, the fact is that today, more and more people are coming out and ready to take a treatment. They are breaking the shackles. They are breaking the shackles of the taboo, the society taunts, the stigma, the apprehensions, and they are willing to come in for a treatment. And of course, results are there. Many a smile on the prior smileless faces have literally filled all our hearts with joy. So simultaneously, along with infertility, developed a subject called embryology. Now, this embryology is a paramedical subject which till date, and as per the ICMR guidelines today, a student, BSc, MSc, life science, biotechnology, microbiology, can enroll themselves. Do a course, there is a 10 to 2-year degree course, there are some in-house courses, or if you get attached to any good laboratory, you start working from the basics. But mark my words, please, this is not an overnight success. It takes a long time for you to modulate yourself, to bring you into the challenging field, understand the basics, the tips and tricks, increase the finesse in working, and it needs a lot of knowledge in all parallel allied fields, including physics, chemistry, maths, etc., etc., etc. It is just not a piecemeal work. I do this and I finito, I'm over. This is not mere a technologist's job. This is the brain work inculcated with your actions. The 3 modules which we have selected, basic andrology, female infertility, and the 3 techniques. This is just a part of a well-modulated big program series, whereas there are multiple aspects and avenues like lab setup, gadgetry, cryobiology, media, quality control, disposables, counseling, etc., etc., etc. But why I have taken andrology as the first build-up step? If any student who has dreams of pursuing embryology, andrology is the first step. And embryology doesn't stop at the clinical aspect. There are lots of fields: implantation embryology, implantation genetics, PGD, pre-implantation genetic studies, stem cell. The list is endless and it is growing. But to get a proficiency in all this, you ought to know the simple basics of embryology And to all students who may be citing this webinar, the first advice is to be thorough as far as endocrinology of male and female reproduction is concerned. So with this, I just start my presentation. Now, every great advance in science is issued from a new audacity of imagination. So remember, till date, I tell all my junior students, whatever doubt you have in mind, please make it clear, because in this field or in science, you cannot proceed further if you haven't cleared the existing doubt in your mind, because then it is just a copybook, step-by-step galloping progress which you are going to make. Now, this field of andrology, initially it was just urology. We were all urologists. Now, andrology is a subset of urology. Till 1960s, when it got recognized as a specialty, and then started the publication of the journals Andrology, Andrologia, Acta Andrologica. Now this started exactly devoting themselves to the problems as far as reproductive system of men are concerned. So that's the reason today andrology forms a core backbone of your embryology setup. Your ICMR guidelines today state that if you have an IVF lab, the team should consist of a gynecologist, infertility specialist, who is she or he, andrologist, anesthesiologist, sonologist, pathologist, and an embryologist, and an anesthesiologist. So this is a team. Teamwork works. So this has made andrology more important, because today we are seeing a rapid or a galloping increase in male infertility. Previously, it was thought females are just the target of infertility. The male, I am right, nothing is wrong with me. Whatever is the problem lies with the females. So this had made them a target, sort of guinea pigs. Techniques have evolved. Innovations have taken place. Gadgetries have progressed. Media has progressed. So much so that testing has become simple and easy and non-traumatic. But still, what makes this andrology more easy and simple? The male gametes, the sperm, are easily available. Masturbation, manipulation, the sperm sample is made available. You can check. So, in order to help us rule out any male infertility related problems, it becomes very easy. Now compare that with the female, wherein the female gametes, the oocytes, are always in vivo. What we depend upon? We depend upon ultrasonology findings, USG, backed by hormone levels, estimation. We presume that they are developing inside. We can't see them unless and until there is an interventional procedure, what we call it as ovum pickup, which we will deal in the last topic. So this has made andrology more challenging, more easy, more innovative, and more easy to learn. So for every embryologist, the first step in embryology is via andrology. Now, sperm were first discovered or observed. Otto van Leeuwenhoek, who happened to discover the first microscope too, and there was an imagination or the preformationist theory that a whole animalcule is compacted into the so-called acrosome of the sperm. And this was what the general belief it was at that time. And today, the sperm or the male gamete, because embryology is nothing else but a fusion between the most motile cell of the body, the sperm, and the largest cell of the body, but the most sensitive and delicate cell of the body, that's the oocyte. And both of them will come to the fruition unless and until they are not chemically primed or chemically activated. Because if I keep an OCC or oocyte cumulus complex and I keep a sperm, I mix them, what I'm going to get is within 5 hours, it will be total degeneration. So there are chemical procedures, there are steps, there are priming methods, there are activation methods, prior to which these two cells can be brought together, can be pronucleated together, and then will start the systematic flow pattern of a culture in embryology, right? From pronuclear stage, 2-cell, 4-cell, 6-cell, modulation, compaction, blastulation. So for a common man or a common nomenclature, these are all the paths. These are the generalized areas of the sperm. And this is a detailed mole biological aspect, wherein the separate enzymes are classified, the mole biological factors are classified. So a general criteria for morphologically normal spermatozoa. A dynamic structure, a dynamic motile structure divided into 3 parts, head, midpiece, and tail, each having a different function.
Dr. Casey, apologies. I
Yes.
think your slides are not changing.
No, it's changed right now. Can you see this criteria for morphologically normal spermatozoa? Hello?
Doctor, no, it's still
It's
on
still
your
the
first
first slide.
slide.
It's still the first slide. Apologies. It's still the
First
first
slide?
slide. I think you need to click on the left side column. Right. Now it's changing. Yes.
Now it changed?
Yes. Now it has
Okay,
gone
fine.
to number 6. It's gone
One
to number
second.
6.
So you had seen this?
No, nothing except the first slide, is it?
So you should have, I don't know how come that's happening.
All right.
One second. Anyway, so when this was my first, okay. Then this was my second. Then this was the next. Can you see them now?
Yes, yes. Now
Perfect.
it's changing. Now
Yeah.
it's changing.
Yeah. And now this is the one which I'm trying to tell you that this is how a good active motile sperm is broken up into its 3 parts: the head, the midpiece, and the tail. Each has a separate function: genetic, energy transmitting, the tail, the whiplash motion, locomotion. Because even in normal intercourse or the simplest step of ART or the basics of ART, that is intrauterine insemination or IVF, motility. So when the sperm gets activated, the midpiece, which is a packet of mitochondria, the activation is maximum at 37 degrees. But remember, hypo and hypothermia both are traumatic for the sperm. The ATP is transferred to the tail whiplashes. So thereby subsequently what we break it is as the motility. Motility, linearity. And another thing is yawing, which I will subsequently come to you in the subsequent slides. So these are the criteria. Now, based on these criteria, we have judged upon the morphological evaluation of the sperm by the Strix criteria and the WHO criteria, which are quite similar, because this is an ideal spermiogram. I think there is some problem.
No, not really. If you click on number 7 in the left-hand side column, it will change.
Fine.
Yes, it's
now, which hormones are responsible? FSH, the follicle stimulating hormone, the luteinizing hormone, and the endogenously prepared hormone in the males, the testosterone. Now, basically, these are all gonadotrophic hormones controlled by gonadotrophic releasing factor from the hypothalamus. So hypothalamus shoots, targets the anterior pituitary, activates the gonadotropes, activates the gonadotrophic hormones. Fic means they are targeting, just like in a male and a female. The FSH and LH both are of equal importance as far as the process of spermatogenesis in the males is concerned. Now, these are the 3 hormones, their levels as regards the age, the structure, and the formulations. There is also an indigenous hormone secreted by the Sertoli cells, that is inhibin. Now, what does it do? It is a nature's control or a nature's way of control the release of FSH, and thereby it regulates the hypothalamic release. So it is in a sort of a control mode. Negative feedback is very important. So inhibin, indigenously secreted testicular hormone, inhibits GnRH and FSH and controls or keeps into check the activity of the Sertoli cells. How are they controlled? Both the male and the female cells, reproductive cycles, are controlled by a hormonal interaction from the hypothalamus and anterior pituitary and the hormones from the reproductive tissues. So whenever we are targeting, we have to take into consideration the hypothalamo-pituitary gonadal axis. Fine. Now this is the hormonal control in the male. Hypothalamus targets the pituitary, FSH targets the testes, the Sertoli cell compartment, which facilitates spermatogenesis. The intertubular cells, the Leydig cells, they are targeted by the LH, that is luteinizing hormone. This LH also nurses the Sertoli cell, facilitates spermatogenesis. But at the same time, look at the testosterone produced, which has a negative effect on the hypothalamus. So the beautiful interplay of the hormone itself, blessing at one time, regulating at another time. Now, many a times we must have seen that excessive testosterone injections by bodybuilders, athletes, initially proves to be a boon because it initiates spermatogenesis in the first place, increases the body muscle mass, till the time the circulating level of testosterone in the body shoots up to such an alarming level that it sends a negative signal to the pituitary, please stop, I'm already in excess. So this is also one of the reasons why excessive use of anabolic steroids can be a potent reason of male infertility. This diagram will help you understand better because this will show you the actual blood pathway. It is very simple. So what do we understand from this? Whenever a male or a female infertility problem is there, first thing is today we are relying totally, completely on blood hormone levels. So pathology is of prime importance. Sensitivity and the quickness and the accuracy in which the hormones are evolved are of prime importance. How the levels are evolved are prime importance. How your assays are set up. So therefore, today also, as far as the guidelines are concerned, in the guidelines, it is vividly stated. The ICMR guidelines have stated that if you are starting a new laboratory, which is the nearest hormone estimation lab, to what distance it is from your place, so that the blood post collection has to reach the lab immediately in order to prevent the degeneration aspect of the hormones. Because remember, when infertility treatments are given, we go across to the cycles, we go across to hormonal stimulations, starting from day 0 to day 10, because the pituitary is no longer in control. We have to give the body exogenous hormones. Now, this is very, very important. So, for developmental biology students, from where are they evolved? We know the three derms, ecto, meso, endo. Ecto and meso from somatophore, meso and endo from splachnophore. So ultimately, our gametes are from endoderm and from mesoderm. Now we must have known migration, aggravation, settlement, differentiation, organogenesis. It's a long, steady drive. Now coming to the next one, this is your basic core. prior, where radioimmunoassays were not there, what we used to do? We used to take biopsies, testicular biopsy, epididymal biopsy. We used to take a little bit of tissue, and these reproductive tissues are always fixed in a special fixative, that is Bowen's fluid. Bowen's fluid is the mixture of picric acid, glacial acetic acid, and a little bit of formalin. Picric acid has fantastic penetration and it doesn't shrink the tissue. Now let's imagine that if this tissue was shrunk and ultimately paraffin block slides at 5 mu were cut, stained with hematoxylin and eosin, the cytopathological observation would have been difficult. The remark would have been majority of the tissues are shrunken. So previously, we used to have a thing called testicular score. Now this is the germinal epithelium. These are the cells in various stages of development. Spermatogonia A, B, primary spermatocyte, secondary spermatocyte, 3 stages of spermatids, early phase, cap phase, maturing phase, the sperm collecting in the lumen, and they will be going all the way from the tubes into the accessory gland complex and ejaculated outside. Now over here, there is a second battalion of cells, the Leydig cells or the interstitial cells. 5-alpha dihydrotestosterone targets the Sertoli cell, it nurses them, and it accelerates spermatogenesis.
I think slide needs to change.
No, I'm showing the same slide. Hello? Hello?
Okay.
Yeah, I'm showing the same slide. I'm explaining on the same slide. So what happens is now when the sperm are produced, now you know the testes are outside always in the scrotal sac because they cannot bear the harsh temperature of the body. They should be restricted to temperature 1 to 1.5 degrees less. There is only one terrestrial mammal which has the testes inside the body cavity, and that's the elephant. A male elephant has his testes inside the body cavity because his testes is insulated by layers of fat. Now, this testis scrotal sac is controlled by the dartus muscle. So when there is a flight or flight reaction, the testes or the gonads are pulled towards the body as a protection mode. You got my point? So this is how nature takes care of itself. Or in cold season, there is retraction. Because of the muscle, there is a dartus muscle. This dartus muscle will retract the testes back. So this is what we call it as the production place or the production part where your actual male gametes are produced. The production site peps up when the child reaches puberty. The axis gets activated. And why is it called germinal? It's like germinating. This tissue is redundant, barren, till it is irrigated by hormones. It peps up. And everything else being okay, if there are no anatomical disorders, if there are no genetic influences, they will promulgate faster, beautifully, in a systematic pattern, continuous 365 days of the year. So this is the charm of male spermatogenesis. Now this I can draw or I can dissect it, and I'm just showing you how the cells get differentiated. The lumen, where the sperm get collected. And this is the pattern in which the spermatogonia undergoes mitosis, primary spermatocytes, then starts the meiosis. And subsequently, what happens is post spermiation, ultimately, we get the production of spermatozoa. These are the steps. It takes 70 days to complete one entire cycle of spermatogenesis. But the production is continuous. So it keeps on going on and on and on till a time if the gentleman has hypothermia, hyperthermia, he has fever, or he is taking certain drugs for certain treatment, wherein the rate of spermatogenesis is hampered. Or a child has a severe attacks of orchitis or mumps when he was young. It causes a complete suppression. Or a gentleman has a trauma, severe hydrocele, wherein not treated properly, the functional capacity of this testicular tubules is hampered. So the percentage productivity is hampered. Now that's the reason what we analyze in a semen sample is the sperm present in the semen sample. Basically, semen is what? It's a collection of the secretion from the seminal vesicle, prostate, and the bulbourethral cells, glands. And the cells are interspersed or broadcasted amongst them. And this is the male gamete cohort which we get. So when we get a semen analysis report, what do? Is we quantify the sperm, quality, quantity, nature, motility, yawing, etc., etc. So by definition, spermatogenesis, spermiogenesis, and spermiation. Fine. This we have to remember. As I told you, 3 parts, but for a complete functionality of the sperm, all the 3 should coexist together. Now, many a times in certain cases, whereby count is less, or what we call it as oligozoospermia. Motility is less. We call it as asthenozoospermia. The sperm are not functionally viable. They are present, they are alive, but functional viability is less. So thereby we have got 3 options of treatment. IUI, which is comparatively simple, in which only one part of the gamete is harvested outside the body, that's the sperm. IVF, both are harvested out from vivo to vitro, mixed together, nature's selection, you get an embryo. Or intracytoplasmic sperm injection, wherein the male factor is severe, the sperm are not in a position to fertilize the mature oocyte. The sperm is bad, the oocyte is good, the oocyte is bad, the sperm is good, both are bad, and both are good, but there is a psychosomatic stress on the patient. So in that case, the doctor or the gynecologist or the infertility specialist has to decide as to which technique she has to adopt. Because prior to these techniques, there was one natural technique which was timed intercourse. Rupture time, sample is okay, just go and have relations, it will strike the bullseye. But of course, rates were less. But then with the advent of medicines, hormones, improvisation in the quality and the quantity of the oocyte, pepping up of the sperms, antioxidants, vitamins, vitamin E, vitamin C, micronutrients, all are being given a boost. But still, till today, we don't have a proper technique by which we can say with an authority that this is the best sperm and this is the best egg which is going to form an ideal embryo. And even if the best of the best embryos visualization which you see, you cannot say with impunity that this is the embryo which is going to give 100% implantation, because the success of a center is what? The take-home baby rate. The child delivers, the child is taken home. It is not the initial pregnancy rate. No, no, no. Initial pregnancy rate, the beta HCG rate should multiply by a geometric proportion after 2 days, that is 14th day after the embryo transfer and IUI insemination. Then what the sonologist sees, the sonologist does the monitoring, sees a fetal heart or a cardiac activity after 6 weeks. That is an assurance that yes, the lady is carrying a live fetus. And then subsequently starts the developmental phase, the proper formation of the placentation, 3 months where the cake placentation, because humans are hemochorial. And IVF babies or ART babies, unfortunately, post pregnancy also have a risk of abortions. Pregnancies are terminated at any time. So a ratio is, in an ART case, 1 take-home baby, 3 abortions. If you do a statistical interpretation. Anyway, we can take that later. Fine. So here we are. Okay. So male infertility can be broken up into spermatogenic problem and erectile dysfunction. A person who is having problem in spermatogenesis, means the quality and the quantity of the sperm or the male gametes are not proper, can still consummate the marriage, have a satisfactory sexual act, but pregnancy, no. Whereas in erectile dysfunction, the erectile machinery itself is compromised. Though the gametes are there, the sperm are there, but the modus operandi is compromised. So there are two different issues. Treatments are different. Here there is a lot of psychological stress, counseling, medications, certain surgeries, whereas in this case, hormonal evaluation, procedures, and ART techniques are there to help you out. What makes male infertility complex? Because for pregnancy, healthy sperm to be carried to the semen. Now, what if this sounds funny? Because the sperm produced in the testes has to go from the three parts of the epididymis, that is caput, corpus, and cauda epididymitis, the cords, accessory gland complex, the penile part. If there is any problem in this pathway, then there is an obstruction. So this is what we call it as obstructive azoospermia. Production normal, but the highway or the pathway is obstructed somewhere. The same thing happens in ladies also. Just like in the men, there are the cords. In the female, there are the fallopian tubes. Then there should be sufficient sperm in the semen, quantity and quality. So quantity, quality, smooth pathway, smooth progression, greater are the chances. Another medical causes, varicocele. The swelling of the veins, spermatic artery and the vein, which are just running narrow, parallel to the cords because of poor occupational hazards. Continuously sitting cross-legged, tight underclothes, cross-leg, laptops, auto rickshaw drivers, heat. These are all occupation hazards. Infections, ejaculation issue, antibodies, tumors, undescended testes, tubular defects, genetic, chromosomal defects, some sexual related problems, medicines, surgeries. There are lots and lots of problems which can erase up. Other causes, most important, environmental causes, radiation exposure, overheating, drug use, alcohol, tobacco, weight, and most important, obesity. So the biggest thing what we say is, whenever any couple who is obese, whether be it a male or a female, we tell them that please lose weight. But the thing is, you know why they keep on gaining weight? Because when a person is stressed out, one way in which a stress can be regressed or reduced is overeating. They think by overeating and making merry, the stress is eliminated. But no, inadvertently, more damage is being done. Your adrenals get activated. And once the adrenals get activated, Cushing's syndrome, there are so many problems arising, especially if a female is obese. Problems right from monitoring the ovaries to the monitoring of the cycle to the negotiation of the cervix for a transfer, for an IUI insemination. The list is endless. Okay. Yeah. So what we do basically, we study the sperm as far as its morphometry and kind of remember one thing. In a complete aspect of embryology, be the sperm or the egg or the embryo, what we are doing is we are just seeing its appearance, its morphology. There is hardly any test, barring a very few, like the sperm DNA fragmentation. 99.9% of the parameters are all judging by their appearance. So therefore, morphology or morphometry is very important as far as evaluation of the gametes are concerned. Now, why is the head of prime importance? Because it's like a lysosome. Now we have studied the question million times. We must have studied the question when we were in schools. Why is lysosome called the suicidal bag of the cell? Once it goes and it bursts open, it empties of the cell of the other degenerative things and it cleans up the cell. Now the sperm acrosome, once it penetrates or it enters the ooplasm, it decondenses. It blasts open. And the sperm DNA, which is very compacted 6 times more tightly, is been liberated. So the piecemeal effect each part of a sperm plays. Mitochondria gave energy, tail it whiplashed, it propelled. The female cervical mucus capacitated the sperm. In case of an ART technique, we wash the sperm manually in the laboratory. That is known as a sperm wash, the techniques which I'll show it to you. So initial parameters, post-wash or post-capacitated parameters, as far as andrology is concerned, very easy. Reason being sperm available on demand, masturbation, manipulation, and here they are. No interventional procedure. It is cheap. It is simple. So whenever a couple walks into any clinic, the first thing which a infertility specialist asks for from a gentleman is kindly collect and get the sample. The andrologist confirms sample is good. Half of the battle is won. Male factor is out of question. Still, remember, ideal semen reports are also not always 100% conclusive. A semen sample can be excellent in all the aspects, but if small biological damage is there, a person who is severely diabetic, his samples will be excellent, but still fertilization potential is as good as 0. So there are always a darker side to everything. Now, in one line, I have just written a glorified definition of a sperm. How it forms the cortical reaction, how it fuses, and ultimately, the first sign of life, the zygote, which is nothing else but an uncleaved embryo, means you have procreated life of that couple, sibling, into your laboratory. The 2PN, 2 polar nuclei, 2 polar body, is the first sign that the egg has fertilized, which means both the gametes were optimal. Now, if it is IVF or IUI, it is nature's, because unless and until they both were not of pristine quality, they would have never allowed each other to fuse. But in case if there is a problem, less count, less motility, suboptimal oocyte quality, then what we do is we do ICSI, we inject the sperm in the egg and thereby obtain fertilization. So that is natural. By ICSI, it is induced. Now, why is sperm washing so important? A properly washed sperm is responsible for improvising your success rates of any form of ART by at least 15 to 20%. Because subsequently, when the embryo forms from the zygote, there is a time scale. It is just like various steps. The progression has to be specific as per the set criteria. It is like an infant's growth scale. By 1 month or 2 months, it starts turning. By 4 months, it starts grabbing and starts to stand, etc., etc. Similarly, ideal egg, ideal sperm, either by ICSI or IVF or even naturally, will first show a zygote. Subsequently, the zygote will show a 2-cell. Ideally at 25 to 27 hours. Which further progresses, 4-cell at this time, 6-cell, morula, and this is the procedure. If there is a lag phase, suppose somebody tells me that Dr. Kersi, 60 hours, I have got 4 good embryos, 4 cell grade 1, what shall I do? I simply ask them, what is the timing? They say it is 60 hours. I tell them, just throw them away. Though they are progressing, though they may be grade 1, though they may be flawless, but they are not on that exact time scale of development. They are having either a lag phase or an arrested growth phase, maybe due to the genetic inculcation or maybe due to suboptimal laboratory condition. We cannot comment as of now, but a properly primed egg and a properly capacitated sperm should give you a zygote which subsequently progresses all the way to the blastocyst on day 5, keeping into mind the right stage at the right time. There can be a leeway of say half an hour, because a cohort of eggs, all the eggs are not going to behave the same. So this is the importance of you priming the gametes perfectly in a perfect condition. So this is what we call it as optimization of your cycles. Because in embryology, remember one thing, you can never ensure a pregnancy. You can enhance the chances of a pregnancy. Nobody is sure. Ideally, there are something like 154 parameters which are needed for an ideal take-home baby, out of which we are in control of hardly 30 to 35. The rest of the things which happen in vivo, and the most important or the most challenging of them all is implantation endocrinology. The embryo and the uterus, the chemical talk between the two, the synchronization of them. That's a little in details later on. So this is the general definition of semen by the WHO criteria. Okay. Now, every year or every few years, WHO sends its booklets or recommendations. Now, this was just hardly 2 months prior, the 6th edition. You can download them easily from the net. So these were the ones, 1980, 87, 92. Now, can you see one thing? Majority of the parameters are quite the same. But as years have gone, look at the normal forms. First, they were saying 50% are always normal in every ejaculated sample, which dropped down to 30, 14, and now it's a decimal 4. Only 4% of the sperm, even in the case of a most fertile man, are normal. Now, this makes andrology the biggest challenging field. And this makes sperm investigation class apart or miles apart from your routine 5-10 minutes pathological investigation. Here it needs the skill of the embryologist, the sighting, the visualization, and the interpretation. Usually, if I give you a drop, I'll see a number of sperm moving motile here and there. I'm saying fantastic sample, but no. Unless and until certain parameters are not justified, you cannot give a consent or a green signal to the sample. So this is what makes the sperm selection absolutely challenging. 4% just normal out of 100. So you can imagine in case of severe oligozoospermic sample where the count is less than 1 million, how much normal form do you expect to get? It's like a needle in a haystack. Well, so now you must be all aware of this male reproductive system. But the challenge over here will be that in an andrology lab, suppose I'm given a container, the sample comes to me. What will be my first visual interpretation of the sample? The volume, a color, the nature, whether it is viscous or free-flowing, the pH. Let's correlate with the glands. Production, testes. The first accessory gland, epididymis. Caput, corpus, cauda. Maturation, transport, storage. So many a times the gentlemen who have got obstructive azoospermia have a blockage over here. The sperm are produced, but unfortunately, they are not being made to go over there. In normal cases, due to the excitation of what you call it as impulse, orgasmic effect, nervous interpretation, because humans can be having tactile, visual stimulation, and in animals, an added is olfactory. A dog, on smelling the scent of a female's urine, can make out the age of that dog or the bitch, whether she is in distress or not. So much powerful is a sensory mechanism. Now imagine everything being normal, the sperm go across, mix with the prostatic and the seminal vesicle secretions, comes out through this tract, which is common, the urethral opening for the urine as well as the semen. So there are different phases. Excitation phase, a little plateau. Lubrication phase, wherein the bulbous gland or the Cowper's gland will give some secretion to wash off the old residue of the urine, because urine is acidic. It can compromise with the quality of the sperm. Then starts the first pulsatile pressure, the ejaculatory phase. So the prostatic secretion along with the first testicular ejaculate will zoom out. So the first squirt of the ejection or the ejaculation contains the most motile sperm. So whenever a gentleman is given the container for collection, we have to counsel them, okay, please see that there is no spillage. If there is spillage, report it to the lab. Report it whether it's the first spillage or the last spillage, because accordingly the results will vary. And last but not the least, the seminal vesicles pump in aggression, and they contribute a chunk to the volume of the semen. So in a semen sample, 80 to 85% is the seminal vesicle content, which is always basic, alkaline. Prostate is 5 to 10%, which is always acidic. Bulbourethral is just micro droplets, say 1, I would say even less than. The rest is the testicular and the epididymal secretion. So judged by the volume, the pH, and the nature, an andrologist can easily interpret the condition of the male. So therefore, all these act in unison. Now, this is how the secretions are. This is the quantity average. This is the pH. And this is usually the content in a semen. A semen is a plethora of flora and fauna. Bacterial load is also there. Therefore, in embryology, raw semen or neat semen is never allowed into the culture lab. There are separate incubators for culturing them. Okay? Now, many times, a gentleman suffers from these three things: prostatitis, seminal vesiculitis, and hemospermia. Now, it is seen, I think even in ladies it's there, there have been cases of a person feeling the sensation to urinate or micturate quite often, within a few minutes, and the amount of urine they void is very less. It is accompanied by continuous irritation, burning. Well, there can be a lower UTI infection, or then can be infection of the prostate. That's prostatitis. So what to do? Do a semen analysis and do a routine urine. If there are excessive pus cells in the urine, well, UTI infection is high. Or if there are excessive pus cells in the semen, there is chance of prostatitis. Second example, sometimes gentlemen give semen volumes 7 ml, 8 ml, huge, very waterish consistency. The coloration is quite yellowish. The sperm are present, but very compromised wavy motility. And if you do a 24-hour sperm survival test in such cases, they will always be bacteria positive. Now, what we should remember is both seminal vesicle and prostate are secretory glands. So in them, they have got those tubules, And each tubule is lined by tall, columnar, striated, epithelial secretory cells. So whenever there is an infection, these glands give out excessive secretion to wash off the infection, just like we lacrimate when something goes in the eye. So as a result, the volume of the semen becomes large. Last one, hemospermia, blood in the semen. When the semen comes with this coloration, or there is a tinge of pinkish, please remember there is blood, RBCs. The gentleman is either suffering from prostate problem, prostatic cancer, bladder cancer, severe infection of the bladder, or the lower urethral infection. Whenever such a case is there, please refer him straight to an andrologist and suggest a definite treatment for him. Because many a times such things go unnoticed without the patient realizing what is wrong with him. Now, in case of prostatitis, the burning sensation will tell him. Seminal vesiculitis, maybe he might be happy, oh, lovely big part of an ejaculate, the huge ejaculate is there, but he doesn't realize that there's an infection. Okay, so these are the things which should not observe the skilled eye of a very good semanologist. Now, these are collection tips and tricks. Please, this is not blood collection that you push in a hypodermic, pull out whatever it is there, bingo, you get a pathological report. The semen is collected as a manifestation of a comfort zone in the mind's psychological setup. If a person is psychologically upset, stressed out, forget collection, he won't be even having an erection. So to eliminate the anxiety, what is recommended? A very nice collection room with a homely ambience, a couch, a sofa, a wash basin, a urinal. Don't keep soap because gentlemen lubricate for collection and soap is toxic because it is alkaline. And tell him that there will be a no knock sign on the door for at least half an hour. Because this is what they are psyched about. Because many collection rooms, sorry to say, which I have seen, 6 out of 10 are pathetic toilets. It's a disaster. Already the patient is stressed out. Second thing, many a times these collection rooms are substituted for changing room, storage room, and just a couch in a corner. That doesn't make it a collection room. Tell the gentleman that if a person is not able to collect manually within the first half an hour, he will not be in a position to collect the semen sample. And afterwards, even a TISA-PISA also will not be sufficient because the epididymal musculature will go flaccid. There won't be a chance for the needle to go in and pull out the epididymal aspirate. So when you take the history, when you counsel, ask him, is there a collection issue? Are you comfortable? Are you comfortable only in the 4 walls of your home or over here also? Make a point of it. So next time on the faithful day of the wife having taken the injection, the stimulation is all ready and he is not able to collect the sample. Don't wait till the disaster day. Okay. Ideal collection method, manipulation, because some people try coitus interruptus, but it's very difficult to maintain coitus interruptus. I would say 99.5% of the sample, the first part of the ejaculate is always lost. But still, it's his wish. He says, sir, aisa hota hi nahi hai. Some people can collect very easily in hand manipulation, and in intercourse, they can't ejaculate. Some can ejaculate aaram se, but in hand manipulation, they can't do. There are various issues of collection that can result into a huge 2-hour talk. And most important is a gap of 3 days because we want the sperm reservoir to build in the body. Now here there is another crux. We tell them that 3 days are kept so that the sperm reservoir will build up. So they quietly keep a gap of 10 days and come. Okay, sir, volume acha rahega, sperm achhe milenge. So this is all we have to tell, the pros and the cons. Then comes the container. Please, please, please. A large, wide mouth, plastic, sterile, bio-friendly plastic, not having any embryo toxicity, should be given to the patient, not the small glass jars. You don't expect the gentlemen to be sharpshooters. And if a collection is not done in the lab, give him the logistics of home collection. But please, there have been cases of sample switchover, bringing somebody else's sample. So you have to give him a format in which it is written that we, Mr. and Mrs. blah blah, have collected the sample to be processed in the blah 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 laboratory on this date, signed by both of them together. Spillage, as I told you, and added assistance is a vibrator or an electroejaculator, which I'll come across in the next slide. Now, you can just go across this slide fast because it has a text material like incomplete sample should not be analyzed in case of the first ejaculate is lost. Transportation, if it's a home collection, try to get it as early as possible within half an hour, because if you tell them half an hour, they'll get in 45 minutes or 1 hour, depending upon the traffic, the congestion, and the stress. Okay. Yeah. Once you collect, the sample is collected ideally in the mornings. The gentlemen, once they give, they think that anything comes out, we just deposit the bottle and rush across. No, that can be a disaster. He can just collect the initial dribble of the bulbourethral glands or a little prostatic secretion and then say, sir, semen collection ho gaya, hum abhi ghar jate hain, kaam pe jate hain. No. So you tell the gentleman to wait in the lobby, do a spot observation. Analyze the volume, nature, pH, color, just drop. Now, this is where your gadgetry comes into play. Your good quality microscopes, your objectives, 10, 20, 40, 100x, binocular or trinocular when you can judge it properly. Your hot block where you aliquot the semen so it remains perfectly motile at 37 degrees. So slowly, slowly, there is an interplay of all avenues of ART rolling into one. Correct? So judge them. You find the sample up to your appreciation. Tell them, sample sahi hai, aap ja sakte ho. If there is a problem, tell them, was there a difficulty? Was there a spillage? Was there a proper abstinence? Were you suffering from fever or something? First, they will be feeling shy. But tell them that, listen, you tell us the right thing because the wife's cycle is at stake. She has to undergo the whole procedure. Otherwise, it's down the drain. Then they will slowly confide into you. Ke, haan, sir, thoda shuruat ka hissa gira tha, last wala hissa gira tha. You jot down. Spillage, first part, spillage, last part, improper collection. You got it. We have to provide a comfort zone to the patient and a sense of assurance to the patient whenever possible, so as to break the inhibitions of the trauma which the poor person has in his mind. Because of course the cost factor is there, the physical trauma is there, then the apprehension of the success is there. So all this literally shatters the mental network of a poor infertile couple. So once we finish the spot observation, here we are. Okay. Yes. Now, this is a challenging field. What if no sperm? This is anejaculation or aspermia. Many a times it happens. A person who delivered the sample in a jiffy on any other normal day, on the day of the procedure, he just goes into a shell. He just can't collect. The poor fellow tries his level best for more than half an hour, ultimately says, doctor, nahi hota hai. Well, it's a disaster. It's a trauma because remember, he has spent the money for this wife's cycle. The wife is stimulated, injections are given, she is about to rupture, and here we don't have the goddamn sample. It's not an isolated case. As 5 to 10% of the males experience difficulty, some have not, some can't masturbate, and sorry to say, some haven't masturbated in their lives. Because of those pressure, it is bad for health. There was a belief that one part of semen contains 10 drops, one drop of sperm contains 10 drops of blood. So it is very unhygienic. It is trauma to the health. It is not permitted, blah, 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 blah. So all those negative inhibitions have literally torn the person apart. So what we can do is, in such cases, you give them some remedy. A non-spermicidal condom on the erected penis can, and whenever he can manipulate or correct, just get it up. Coitus interruptus or a vibrator, which I'll show you in the next slide. Now, 90% of the males have to be counseled properly. And the apprehensions and the conscious inhibitors have to be erased. Because they have never experienced this thing prior. Till today. So what we got to do is we have to reassure the faith in them. Okay, no, this is not the case. It is always what you call rectifiable. You just go ahead. Because what they face is anxiety, situational anxiety. Suddenly a collection room, a container, go and collect the sample. Oh my God. Performance, wife cycle is at stake. I have invested $1,000, more than $1,000 in this cycle. What if she goes with? What if I can't do? That's performance anxiety. Many turnoffs. Oh my gosh, this room, I can't even stand over here for 5 minutes. How can I do collection? Pathetic container. Oh God. High expectation, the gynec will tell him, देखो, आज cycle है, बराबर से sample collect कीजिएगा, नहीं तो Mrs. का cycle waste हो जाएगा. So please don't do that. Don't traumatize him. Or there can be other psychological problem in which a patient just can't have total ejaculation. There could be a whole topic on this, the male ejaculatory problems. Unfortunately, not within this scope. So you have to consult a urologist and a psychiatrist. Sorry. Yeah. Now this is periovulatory anejaculation. Now, what does this mean? That a person can't ejaculate when you exactly need it the most. Otherwise else, it's at the drop of a hat. So what to do in such cases? Whenever you know of such apprehensions are going to happen, do a cryo backup, freeze this semen sample. On that day, give him a little bit of Viagra support to pep him up, because he will feel at the back of his mind, oh, I have been treated. Now, many times it so happens that he is perfectly all right when he comes to an andrologist. The andrologist says, sir, तुम्हें कोई issue नहीं है. नहीं, ये डॉक्टर ने मेरे को दवा नहीं दिया. ये डॉक्टर को कुछ मालूम नहीं. But if we give them a little bit of a placebo, he will be still happy. Now I'm going to be treated perfectly fine. I'll deliver the season. And last but not the least, practice on the vibrator to him to get some more confidence. Yeah. Then clinical anejaculation. You are sitting in a lobby. The sister comes and shouts, Mr. So-and-so, take the container, collect the sample. So this itself is a turn-off because there is a lack of privacy amongst the others. Collection room, hostile approach. So what remedy is there? Constructive counseling, reassurance, and the logistics of home collection. Now, over here, this is a very nice, very simple gadget, the vibrator. It's like a body massager, but it is very effective in persons who are having little or initial apprehensions in collection. Make the person calm, give him some erotic literature, or let his partner accompany into the collection room. He will be having a semi-erection. And at that time, keep this machine with the pad below the shaft or the prepuce on the tip on the lower part, because that is the place which is very richly innervated. The machine starts vibrating, gives the orgasmic effect, and suddenly he'll come up into a collection. It is successful 70% of the times. But please, don't thrust the machine into his hands on the first day. Give him some time to get acclimatized with the machine. He should take it home, practice it in the periovulatory period. Believe me, some people have fallen literally in love with this machine, and they have personally bought it. Okay, sir, जब भी चाहे हम लेकर collect कर सकते हैं. Okay. Then the next one, in case of a serious problem. 1 second. Yeah, that's it. Yeah, this is electroejaculation. Sometimes when a person is incapacitated below the waist, serious nerve issues, that time erection is out of question. The pudendal block is gone for a toss. So what is done is, this is also mimicking, but it's a little invasive. This is the machine, which is an electroejaculator. This is a probe, or what is called an anal probe. A person is under anesthesia. This is lubricated, inserted into the anus. Slowly the voltage is turned. So this is a transrectal electrode. Temperature sensors are there in order to prevent the scarring of the tissue. Slowly, slowly it vibrates. He is under, of course, general anesthesia. So the vibrator rod goes inside. The seminal vesicle and the prostate are massaged by the vibrating effect, and the semen gets collected. Now here, this procedure can't be repeated off and on. So once you collect, this has to be frozen. Immediately cryopreserve. The motility is always compromised. So in electroejaculated sample, always ICSI is done because the sperm have lost the capacity to move. The organic problems, urinary tract fibrosis, prostatic fossa fibrosis, lumbar sympathectomy, and autonomic neuropathy. Embryologist, surgery, and counseling all play a very nice part into this. And if spermatogenesis also is proper, then definitely the cohort of sperm in the ejaculate will definitely be worth appreciating. So the moment you collect, wash the sample, retrieve the sperm, finish off the ICSI. Then there is retrograde. What we are having is antegrade. Retro means going back. Like just imagine epiglottis, the valve, flap, esophagus and windpipe. When I breathe, esophagus is closed, windpipe is open, trachea. When I eat, it's the other way around. Now, similarly, in this case, sperm, when ejaculated, goes all the way. Otherwise would have come out like here. But in this case, over here, due to the malfunctioning of the bladder, the sperm get retrograded into the urine. So the semen mixes with the urine. So the gentleman has a feeling he is masturbating. He has ejaculated, but nothing comes in the container. So what happens? All the things are collected over here. So this is a mixture of urine plus the sperm. Right? Now, the question is how to retrieve it. So this is it. The male reaches an orgasm, but there is a failure of emission. So bladder neck cut, injury in the pelvis, non-functional, prior prostate or urethral surgery, diabetes, certain drugs for high BP. These are all the reasons. And how will we recover? We have to recover the sperm from the urine. So first we have to neutralize the urine shock, acidic shock. So he is made to drink this cital to nullify the acidity for 2-3 days. On the day of the procedure, excite him or excitatory phase, tell him to masturbate. Again, no collection, 10 minutes waiting time, collect all the urine, spin it fast, collect all the pellets, put the sperm media, retrieve the sperm. Very tricky. And results are not all that appreciative. But this is definitely a trick by which we can retrieve the sperm. Then the next is cryptozoospermia, hidden sperm. And ejaculate. One lab reports no sperm, second lab reports no sperm, third lab reports occasional sperm present with poor motility. So that doesn't mean that the first 2 labs were wrong. The seminal tubule, seminiferous tubule is long. It is compacted. So one part suddenly shows a spurt of spermatogenesis at some time, and that part suddenly comes into the ejaculate. So you will feel 1 or 2 sperms suddenly twitching across. And the finding of even 1 sperm will tell you that the person cannot be branded azoospermic. So what we got to do? We got to spin the sample, collect the pellet, tease the pellet, find out the sperm. So it is called crypto. Crypto means hidden. Now, problem is how to report such things. So here you have to be a little political in writing the report. Suppose we spin but still we don't get a sperm. So what do we write? No motile or non-motile sperm in the wet specimen nor the centrifuge pellet. Kindly repeat the analysis to confirm the findings. Even if we get it, please repeat the findings. Now we don't get the sperm in both the cases, 3, 4, 5 times. Then it is time to send him to an andrologist. He will give him a physical examination, check the testes, the epididymis, the functionality of the cords to see if there is any blockage. Years ago, we used to have a thing called orchidometer, the different sizes by which we can judge the size of the testes respective to the age of the patient. Then the hormonal estimation, then keep him on hormones. There is a slight spurt in spermatogenesis, do a semen analysis, whatever is retrievable, freeze the sperm, and at that time do the ICSI. So this is what we call it as remedial methods. So if we were to go by the sperm kinetomatics, now these are detailed kinetomatics, which is done by CASA, computer-assisted semen analysis. They see the curvilinear velocity, they see the path velocity, they see the straight line velocity. It's a little too much. We term it by the human eye like this, progressive and non-progressive. And this is the speed. So in our latest guidelines, WHO has written, there are 2 types of motilities, progressive and non-progressive. They may be active, they may be moderate, and they may be sluggish. Now, this is how you will see a sperm going as a lateral amplitude. This is a diagrammatic thing. The sperm comes, the majority of them attack the zona. The hyaluronidase digest the granulosa cells. One sperm goes, there's the membrane reaction or the ulema reaction, goes in, decondenses, the acrosome and the tail leaves behind, then starts the formation of the zygote. So this is the pathway towards fertilization. And this is just a pathway of how the sperm lateral amplitude means. Now, active and linear, there are 2 issues. A sperm can be active forward, but sperm can't be linear. But a linear sperm has to be active forward. Because linearity is to travel in a straight line. Active means to go fast. Because remember, the sperm have to encounter the battle which they face with the cervical mucus of the female. So howsoever excellent your sperm count and motility will be, they have to penetrate through the layers of cervical mucus, which are the natural barriers or the filters in a normal case. If the female's estrogenicity is less, the mucus is hostile. It's like a barrier. If the mucus is brittle, the spin market is not good, the sperm will find it difficult to gain. So this controlling the nature of the mucus, the quality of the mucus, is also a female contraception, or what we call it as hormonal contraception, which itself is a chapter in itself. Okay, so we go to the next one. This is yawing. Sperm always move like this. So yawing is what? A body travels in a straight line, but one part of it always changes the plane. Now there are sperm who go like this. That's negative yawing. These are all non-functional sperm. So a yawing is smooth with a lovely whiplash tail. Effective stroke, recovery stroke, effective stroke, recovery stroke. So the number of sperm which zoom across the visible eye field are the most active ones. And once you wash them or once you capacitate them, their linearity, their progression activity, and that activation potential shoots up. So that's the logic which we utilize in andrology when we say we are washing the sperm. Now, these are the chemical properties. I won't be going them in that detail, but what I would like to tell you is fructose, most important secretion of the seminal vesicle. Zinc, important parameter of the prostate, because sperm breathe anaerobically. Citric acid, ascorbic acid. So these are all vital micronutrients. So whenever a gentleman is kept under those typical tablets like the CoQ enzyme and all that, these are all the contents of that. Physical properties. Now, why I'm saying physical property of a semen, what the hell has semen got to do? Sperm is a cell. It will survive in the media, and the media is seminal plasma. So if the seminal plasma is hostile, the cell won't survive. So the sperm will be having difficulty to survive in the toxic seminal plasma. And one golden thing which all embryologists should realize, that once a semen sample is collected and it is to be processed for the ART procedure, try to eliminate the seminal plasma as quickly as possible, because the longer you keep the sperm in the seminal plasma, the faster will be the drop in the fertilizing capacity. I had seen in labs, oh, आज तो 3 sample आने वाले हैं, let all the 3 samples come, we'll process them together. The motility and all will be unhampered, but the chemical damage or the mole biological damage done on the membrane is invisible. Then you would say, excellent sample, why the hell not she getting fertilized? Because the damage is already done. So seminal plasma has to be eliminated from the semen, from the sperm membrane post collection, if that sample is going to be utilized for any ART wash procedure. Okay. Yeah. Now liquefaction, that's very important. Liquefaction means the tendency of a fluid to fall drop by drop when passed through a dropper, without the 2 drops maintaining any site of contact with each other. Now, what an irony. In a female, the mucus, the vaginal and the cervical mucus, the longer it is thread, it is drawn into a thread which is known as a spin bucket, the more excellent and fertile it is. But in a male, if the semen is drawn into a droplet, I mean in a thread, it is bad, because semen comes out as a coagulum from the seminal vesicle. This coagulum is broken up by the secretion of the prostate, which contains prostatic specific antigen, and this causes decoagulation of the semen. Now, if the semen sample is viscous, slimy, it's a pain to get that sample washed, because it will not form a pellet, it will not allow the media to coat the sperm, and the aspiration will be a headache. Yeah, so this was what I was telling as viscosity. Now, viscosity will be there when there is a higher chance of prostatic infection. A viscous sample will be abounding in a number of pus cells. Now, this is all the seminologist has to see and report, because whatever he sees and reports, please rectify the problem before recruiting the same patient for any sort of a treatment. Your results will definitely improve, as rather than saying, chalo ek baar pehle try kar lete hain, baad mein uska ilaj karenge. That's a disaster. You cannot do that. So this is the unit. Poise is the unit of viscosity, and a human semen averages around about 3 to 7 centipoise. So centipoise is a unit. Now, our seminal plasma. Basically, in a normal intercourse, seminal plasma is a blessing, because it contains the basic amines. And this is the vaginal cytology and the vaginal environment. Hostile for sperm, it is very acidic. Now, this acidic nature is a trauma for the sperm acrosomes. It will denature the DNA. So this DNA is buffered by these amines as a protection. So therefore, we get this typical odory seminiferous odor of the semen, unless and until it's a severe contamination and it gives out a very foul smell. Now, what an irony. In normal case, remember, there is no actual mixing of the cervical mucus and the semen. They just come, there is an interface, and from that the sperm will be filtered out and they will go merrily dancing all the way from the lower os, mid canal, external os, canals, and then to the tubes, and then to the ovaries. So the same seminal plasma which insulated the sperm from the acidic nature is unfortunately also causing a barrier as far as fertilization is concerned, if it is exposed with the sperm for more than half an hour post collection. So these are the biological components, biochemical components, sorry. So look, that's why I've written zinc levels in seminal plasma are associated with sperm quality. So many a times the basic tablet which used to be given, B complex with zinc, that's Zevit. Then antioxidants, vitamin C and vitamin E, Vitamin E, tocopherol acetate, it improvises the motility. And vitamin C, it improves the quality of the semen. So this was a small cocktail of medication which all the infertility patients, the males, howsoever normal they were given as such. One is to give them a psychological stress, so they are also being treated. Excuse me. This is what we discussed, seminal plasma toxin. Now this is important. Why? If a gentleman gets the sample from home, he will tell you, nahi sir, a bitch collect kiya, aadhe ghante pehle hi collect kiya. But when we see the sample, we see a slight wavy motion in all the sperm. Means they are traumatized. They are traumatized by more exposure to the seminal plasma. They are traumatized to the climatic conditions. They are traumatized to the temperature in which they have been brought. And they are also traumatized due to the quality of the container and the material of the container. That's why whenever there is a home collection, make it a point that the couple is given a container from the lab itself with a proper instruction that break the seal only when you are going to use it. Note the time of collection. Don't wash, because some people are overzealous. They even wash the sterile container which we provide them. Agreed. They are under stress, so they will try to do all the level best, thinking that they are right. The problem will lie in us because we are the ones who have not yet counseled them properly. So a proper counseling is a key to all. A counseling session to a first patient should last for at least 1.5 to 2 hours. But still there is a guarantee that 10 patients you counsel, 3 will just walk away and not come back to you again. Yes. Now, capacitation. Now, capacitation means what? Removal of sperm membrane and chemically priming the sperm. Remember, the sperm is like an onion, the sperm head. Layer after layers will be removed. So when we wash it, or what I say is when we capacitate it, what we are doing is we are actually removing each layer out of it. And then we are transferring back all the way into the uterus. We are bypassing the cervical mucus, which otherwise is a very important barrier to filter the bad quality sperm. Now, these are the contents. Okay, secreted from the crypts, estrogen and progesterone. So good quality mucus suggests good quality estrogen, progesterone. Good quality estrogen, progesterone suggests good quality folliculogenesis. Good quality folliculogenesis will give you an idea about how functionally well the follicles will be in the shape of the things to come. Now, this cervical mucus is substituted by us when we are doing the first basic elementary step in andrology, which is the sperm wash. Because a sperm wash media is nothing else but a battery of all these salts and with EDTA and HEPES buffer. HEPES is hydroxyethanol perionic ethanol sulfonic acid. Forget the name. HEPES is a patent name. So HEPES sperm wash buffer. It is very essential. And remember, this media is just to be incubated at 37, contrary to other sperm, other embryological medias, which need equilibration in a CO2 incubator, because they have amongst them carbohydrates and proteins also, whereas this media just has salts and a buffer to ensure their survival and to protect them from the peripheral osmotic and the pH effects. Right? Now, this is this media which we will be utilizing extensively as far as washing of the sperm are concerned. Now, sperm wash, why it is necessary? It eliminates the seminal plasma, reduces the risk of infection from all diseases, and it's a standard procedure in your infertility treatment. It eliminates the seminal bacteria, and it facilitates capacitation. So capacitation is the alteration or the removal of a glycoprotein layer, which activates the sperm further, makes it attract towards the, I would say, primed granulosa cells of a mature oocyte. So there is a chemical talk between them. It's the reception, they get attracted towards it. The more the sperm they attract, the more the denudation, and the faster will be the membrane reaction, resulting into the zygote formation. Yeah. So this is the chemical definition. This is exactly what capacitation means. Now there are two conventional techniques. One is a sperm wash technique, and the another is this for the swim up, and the another is double density discontinuous gradient separation. Now this is a gold standard in which what we have to do is we have to harvest the best quality of the sperm from the complete cohort which we get in the seminal plasma. Now this will be advantageous only if your sperm is near normospermic. Motility count is excellent. Okay. Now this is a conventional swim up. Dilution. You dilute the media. I think I'll simultaneously show you with this. Yeah. First, you dilute the sperm in 1:2. You spin it, get the pellet, discard the supernatant, again mix the pellet, discard the supernatant. So there are two washes, the base and the other one. The first discards the supernatant and the second one washes. You layer it, keep it incubated for half an hour. The best of the best sperm will slowly zoom up from the pellet. You collect the aspirate and you inseminate it. So this is known as harvesting the best quality of the sperm. They will be a fraction of what we saw in the initial motility. Because our idea is take the best sperm, transfer it directly into the uterus, let them follow the way to the tubes and do the fertilization procedure. Two washes are essential. First one is to remove the seminal plasma, and the second one is to wash the pellet. Now imagine or suppose that you are having a suboptimal sample, poor quality, poor motility. So what we got to do is we got to select the devil from the devils. So the another technique is your discontinuous gradient separation, in which I'll show you. You have got two gradients. One is a heavier gradient and one is a lighter gradient, like two filter beds. And on the top, you put the semen, spin it. The best quality of the sperm will start flowing down. As a matter of fact, all solid particulate matter will start flowing down, and they will be trapped at various levels, or what we call it as the interface. The white blood cells will be trapped over here. Debris will be trapped over here. Abnormal will be trapped over here. And the final lovely cohort of the sperm will go down. Now, this quality will give you excellent morphology. So where you are OAT samples, oligo, astheno, teratozoospermic samples, this is the best technique. And this is ideally utilized for ICSI, or intracytoplasmic sperm injection. So there are another sections also, sperm selection in ICSI. If there is male factor, we have to do a testicular aspiration. We can do a percutaneous epididymal sperm aspiration. We separate the sperm by the double density gradient method. Or we have an IMSI objective which is fitted on your stereo zoom, the inverted microscope, which is intra-magnified sperm injection. It magnifies the sperm to 7,000 times. And last is certain pixie dishes. They have got hyaluronan drops. So the good quality sperm will bind to the drop, and we can be sure that this might be a good sperm. Still, as I told you, there is no foolproof method which will ensure you that this is the best sperm. These are not exactly trial and error, but a subjective thing. Now, when you judge a sample, don't go by the books, because the book says this much RPM. You use your common sense. You use your judgment. So always go by first count per ml. Total count means how much ml into the ejaculate, and then find out the total motile sperm count. Now let's take an example. You have 80 million sperm You'll telephone the doctor, says, "Iska report kiya hai, sir, sperm bahut acha, 80 million hai." Then subsequently, you will ask, what is the motility? Motility is 10%. Oh God. So what is 10% out of 80? Hardly 8 million. So what about the rest? 72 million. Well, question mark. So this is what we call it as total motile sperm count. So irrespective of the volume or irrespective, you have to find out the TMSC. And this TMSC will be very helpful when you do a wash and when you recover the sperm from the aspirate. So aapko kya milta hai? Functionally progressive sperm you are getting by these two methods. So just merely by saying, oh, count is good and excellent, don't thump your backs. This is a disaster. Always do the TMSC. Total motile sperm count is very important. So 3 parts as far as motility is concerned: count per ml, volume is 2 ml, so count per ejaculate, 30 million into 2, that brings you 60, 50% is the motility, so the TMSC again comes down to 30. Now this can help you tell a fake IUI report from an original good report. Okay, so remember this and use your judgmental characteristics to select the time of the centrifuge. But remember, when you centrifuge, please see that you don't go past a certain set standard. Ideally, sperm membrane can withstand the centrifugal force, because when a thing centrifuges, there are 2 forces acting on it: centrifugal force and centripetal force. When the centrifugal force goes beyond a certain G factor, more than 300 to 400 G, the sperm membrane undergoes lysis. Or the other weak cells undergo lysis, they remove the products and they contaminate the length of the sperm, resulting in increased ROS, reactive oxygen species. And this brings down the fertilization potential. So sperm centrifugation, safe, 1300 to 1500 RPM, from 10 minutes to 15 minutes, because all foreign authors will write in G force and all Indian authors will write in RPM. So don't confuse between this. This is a very important topic which you always did in QA/QC, the conversion factor. Okay, so this is what we call it as centrifugation induced membrane trauma. Now, you have got CASA, of course, computer assisted semen analysis, takes care of everything. But the only thing in which I trust this machine is just for the morphology, because the way the machine selects the morphologically normal sperm, especially the acrosome, unfortunately, the human eye cannot do, because human eye also has its own restrictions. Now, this one, the eosin testing. I give you an example. 30 million count per ejaculate. Motility is just 5%. So what about the other sperm? Are they alive and they are non-motile, or are they actually dead and they are non-motile? Now, sperm is an animal cell bound by a plasma membrane, trilamellar, lipid protein, flexible, very susceptible to damage, crack, or an injury or an insult. So it may be non-motile because of that, or the membrane may be intact. There is a depreciation of micronutrient. There is an increase of ROS. There is heat-induced trauma. What is the reason? Simple. Do an eosin staining. The sperm which take up the stain, pinkish, they are the ones which are dead. Because of the break in the membrane, the sperm, the color or the stain has penetrated and given the color. The rest of the sperm, though they are non-motile, they are colorless. Now these sperms will be pepped up by change in habits, change in lifestyle, improvisation of ROS. Okay? Vitamin E, vitamin C, zinc, 40 to 45% of motility can be introduced in that. So this is a very simple test. Now, nigrosin was a counter stain which used to give a contrast. But nigrosin is a little harsh one. It masks the effect of the eosin. So many a times we just use 1% or 5% aqueous eosin. Aqueous, water. Please don't use alcohol-based eosin, because alcohol itself will cause shrinkage. Now, last but not the least, morphology. Is it informative or is it decorative? It is very much informative. And that is the basic vital step. Why? The reason is why suboptimal sperm or less number or poor motility are not able to fertilize the best of the best two sites. Now, if I show you this and say which is the best sperm, there will be various answers. But let me tell you, number 4 is the sperm which is quite close to being a normal. Let's say number 1, funny shape. There is a vacuole, abaxial placement. This sperm will rotate. Number 2, brinjal-like shape. Number 3, swollen midpiece. Number 8, round head, swollen midpiece. Nick, vacuolation. So like that, if you see, the more and more you know, the more and more you will come to a conclusion, okay, no, even this is not good. Now see, these are all the stain preparations of abnormal sperm heads. And the sad part is, these ones will have a fantastic power of motility and linearity. They will zoom across like normal ones. So you will be confused. So this is what exactly, there is a certain protocol, whether there is a lift-quick staining, whether there is a pap staining compared to semen to the, what you call it as a ladies cytology, cervical cytology, hematoxylin, Harris hematoxylin, then there is OG6, and there is EA36. 3 counter stains to check up the size of the head, the percentage of the acrosomal cap, the midpiece, and a contrast as far as the tail is concerned. Yeah. Now, there is unfortunately no remedy or no medication for abnormal sperm. Now, this can be due to stress or trauma. That can be temporary, that can be permanent. Because you know why morphology is important. That suppose this is a sperm head coming and this is an oocyte. We always have a tendency to imagine that it will just come, touch tangentially, and it will penetrate. But it's not so. The sperm will come, bend itself, touch the ulema, and the typical pyriform shape, a certain area will touch the ulema. So the critical area which touches is sufficient enough to trigger a mechanism, then the sperm will straighten up and it will enter the oocyte. So the pyriform or the ovoid shape of the acrosome is the key to fertilization. Suppose the sperm is tapering head like this, the contact place will be more. Suppose the sperm is round head, globoid, the contact point will be just a point. Now what happens? In the hypothalamus, there are 2 types of cells, supraoptic and paraventricular. They secrete gonadotropic hormone releasing factor. Now they are situated quite close to the hypothalamic centers which control stress in the brain or in the human body. So whenever a patient is stressed out, whenever a patient is under some psychotic drug treatment, they mask the functioning capacity of those cells. As a result, the whole pituitary axis is shattered. As a result of which, the Sertoli cells which are targeted, in which the proper spermiation takes place like this, is hampered. So the resultant sperm which ooze out are compromised. Now that can be temporary, that can be permanent. Like for when we were students, the onset of exams, January, December, January, Rose Day, College Day, etc., etc. Cometh February, prelims, stress. March, exams coming near. The best of the best dishes were tasteless. The best of the best TV programs were looking horrible. We were just focusing. The day the exams were over, finito. We were all back to square one. The tension is lifted. The axis straightens up. The hormonal balance falls apiece. So we are back to normal. Now, unfortunately, in infertility people, they are poor always under stress. That's the reason why after a certain batch of treatments like forced back-to-back IUIs, if a person is left on his own, there is a 40% chance of those infertile couples becoming pregnant on their own 2 to 3 months after they just said nothing doing to everything. Reason why? The axis shifts. There is a literature study which states, it's an authenticated publication, Fertility Sterility, that even after IVF cycles, when a person has given up, I am finished, let me lead life on my own. So the whole stress factor is erased. So when the stress factor is erased, the gonadotrophic axis slowly comes back into the normalcy, and luckily they are able to conceive. So the bottom line is stress is the evil of all. Fine. So now this one, age relevant. Well, definitely. Sperm count decreases. Sperm are produced less. The mean sperm count reduces. And pregnancies may occur. But the attempt to get a pregnancy post 50 or 60 is definitely more. The maximum attempts are more. And this is how the graph shows you. And this is how the male fertility and the age. We have read newspapers, 70-year-old father, lucky the first one to harbor a child, but that is rubbish. At this age, to harbor a child, to take care, by the time the child comes to maturity, sorry to say, the parents might not be even alive. So who's going to care for the child? So therefore, regarding this also, there are many guidelines in ICMR that beyond a certain cumulative age of the parents, ART cannot be advocated, mother's age, because there will be lots of complications. And the complications, unfortunately, are not on the mother side. So the age of the male is relevant. Production will be there, motility will be there, count will be there, but the functionality will dip. Now, this is how the testosterone level drops down as the age increases. Okay. But still, there will be many unanswered questions. What is the cutoff rate before I do a procedure? What is the minimum requirement? What is the maximum and the minimum? Where am I? What is the leeway which is expected? In any procedure, we are not sure about the absolute success or not. Because even in a simplest procedure like an IUI, we have got pregnancies even in 2 and 3 million counts post-wash, but the kinetomatics are fantastic. So what I'm trying to tell you is that you cannot per se judge the sample by its appearance. What we are trying to do is we are trying to maximize the efficacy of every sample. And andrology is easy. Why? Because by andrology sample preparation, you can do a simplest procedure like an IUI, a high intracervical insemination, or even an advanced thing like an IVF, or the most complicated procedure like an ICSI. So as an embryologist, you cannot say that there is a severe cutoff point. Okay. When you say that there is just 1 or 2 million sperm, normal pregnancy, normal intercourse, the chances will be very, very, very less. So till today, patients question us, what are the success rates of an IVF? We say, well, it ranges from 28 to 38, depends upon the conditions. Oh my God, only this much? So we tell them that with your parameters, you at least have that 30% chance. But without this procedure, even this 30% will not be there for you. You got my point. So you are under this bracket. Now, suppose a gentleman has a problem. Now, I think I have not shown you 2-3 slides. They skipped up in the first when I was just shuffling across. I will be just showing this to you. Just a minute. I think I have covered them. These are the ones which we missed a little bit. Yeah. These were the ones which we missed. I'm sorry. Yes. See, these are the few causes of male infertility. And these are the percentages, how much they occur. Now, many times there are unexplained. Now, what is unexplained? Some say unexplained means they are undetected. Means sometimes what happens is, you do a test, it comes normal. You do a test, it comes normal. And the patient gets stressed out. I think there should be some goddamn test which is positive in me. So I'm sure this is the reason why I'm not getting pregnant. You got my point. It's the converse. Now, in a male, there can be a vas deferens block. There can be undescended testes. There can be varicocele, what I told you, the swelling of the arteries, veins, and clumping the tubes. or the spermatic cords, thereby preventing the passage of the sperm. Or there can be vasectomy and a reversal. Now, reversal is not always successful. Vasotomy is not always successful. Then there are other problems, what we call it as ejaculatory disorders. Person can produce, person can ejaculate, but the way and the manner he ejaculates is funny, which can be termed as premature, delayed, retrograde, or anejaculation. Okay, so this is a normal ejaculation. The ejection of sperm and seminal fluid during an orgasm in a male. The transport, production, stoppage, maturation, delivery, mixing, ejection, which is a mixture of neurological and excitatory phases, or this is what we call it as an orgasmic phase, during which the heartbeat goes in, the heart rate goes down, the blood velocity, the blood capillary gets activated, body temperature rises, and our mind is just focused as if we are wearing a blinder. So these are the 3 steps, or these are the few steps. Now, this is PE, premature ejaculation. Ejaculated too soon, then suddenly a loss of erection. There is no time to enjoy. Actually, the research, I've got a huge publication on this, ejaculatory disorders. So it is taken an average of 5 to 7 minutes for a man to reach an orgasm and ejaculate, but the range is wide. Then in this, they are further evaluated by what we call it as intravaginal ejaculatory time. Premature ejaculation is very less, normal is say 4 to 10, delayed, and anejaculation is, of course, no semen at all. Now, delayed ejaculation, or what we call it as sometimes dry ejaculation, is absolutely no sperm, and delayed means post-climax. Okay. Now, it is very difficult for even a patient sometimes to interpret his problems. Anejaculation, or what we call it as dry ejaculation, thunder without the port. So these are all the things which will be the forte of a skilled andrologist, not just the embryologist, because embryologist can just talk or counsel with the couple. The problems which he has to be listed down, those not within the forte of the lab. Definitely they have to be consulted to an andrologist in their individual capacity. Let's see if I haven't missed out any other slide. That should be enough, I presume. 1 second. Yeah, this is the most important slide. Sperm have heads but no brains. We have to use our brains when we use their heads. They are too blessed to be stressed. Fine. So this is my last slide. Thank you for a patient hearing. I know this topic of andrology is a little boring, but for the youngsters who really want to make their foray into the field of embryology, this is the basics they should be knowing before they step into the threshold of any andrology laboratory. I think now I'm done. Somebody can take over.
Thank you, Dr. Awari. Now we have a few questions for you.
Yeah.
Andrea, are you here? Andrea?
Yes, Karen.
Yeah. So I'll hand over the questions to Andrea to forward it to Dr. Awari.
Yes, doctor. So our first question, Karishma Naik asks, what is the lag phase and the arrest phase?
In what? In the development procedure of embryology?
No, I'm not sure, sir. I don't think that is mentioned.
That's what exactly I was telling, that when I showed the embryology development scale, if your gametes are excellent, if your culture conditions are excellent and the QA/QC is excellent, the developmental procedural phase, which will show from one step to another, should exactly fall within the tenets of the marked time. Now, if there is compromise at any stage, in the media is not equilibrated, the gametes are not of a good quality, then what they do, the developmental procedure will slowly shorten or lessen up. This is known as a lag phase. So the good ones will show a 4 cell, where there were some ones which are lagging will still show 2 cell. And that it can be possible due to organelle induced hypertrophy or work induced hypertrophy, because if you are providing them suboptimal conditions, the mitochondria, the Golgi, and all the cellular cytoarchitecture will not function at its best. So they will try to do their level best. It's like, whipping a dead horse till such a time that they will collapse. That will be known as an embryo developmental arrest. But in spite of that, slowly dragging their way ahead, that is known as a lag phase.
Thank you, Doctor. We have the next question by Ms. Anishka. She asks, what could be the reason behind the drastic reduction in the amount of normal sperms?
There are so many reasons. Now, a sperm sample of a person who delivers, say, today morning at 10 o'clock, if it is 60 million with 80% motility, if he goes any stress, tension, or maybe just not in the mood to collect, if he's not in the typical orgasmic phase to collect, the evening sample will show a collection of 10 million with 5% motility. So much vast will be the variations. As I told you, this is not blood care. Anytime you pull in and pull out what it is a manifestation of so many parameters put together.
Thank you,
Plus,
Doctor.
of course, one thing, but if he is suffering from some disease or a problem, that needs to be rectified. Now, suppose you say last month, this report was 80 million, and subsequently 3-4 collections after 2 months are showing a drastic decrease. There is something problematic somewhere going down. So again, the volume, the pH, the nature, the hormone levels, post investigation, it can be simple, it can be heterogenic, whatever it is. That depends upon the teamwork which investigates him. That's the reason we have primary fertility, infertility, and secondary. Primary, of course, post-marriage, all are firing great guns. Suppose time goes by, stresses develop, difference of opinion, blah, 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 blah. The list is endless. So they are having a difficulty in trying a second child, which is secondary infertility.
Thank you, Doctor. The next question, we have Riddhi. She asked, does the sperm quality in men get affected due to the type of lifestyle?
Oh, yes, very much. What lifestyle you want me to say? First of all is stress, cortisol, okay? Habits, smoking, lazy cilia syndrome, nicotine contamination. Then temperature, tight fitting underclothes, the scrotal sac are completely compressed, heat, peripheral effects, radiation, environmental effects, okay? Plus, most important, the stress, because if there is stress on a person's mind, erectile problems will be more. If erectile problems are more, ejaculatory issues are more. So if a person, he won't get an erection, he will get a psychological stress. Oh my gosh, I hope I'm not becoming impotent. So that will again lead to a negative feedback and crash down the sperm level. So it's a lovely web which is knit closely like a Spider-Man. It's like that.
Thank you, Doctor. We have the next question. This is by Tapaswi. What are all the tests to be done in a couple who is planning for pregnancy?
Oh my God, the list is endless. See, but as far as this embryology is concerned, first thing what we do is a spot collection irrespective of the abstinence. Because at that time, the person is also confident. Sometimes it hits a jackpot. First collection is so fantastic that, okay, we say he's out of danger now. We are perfect. We have won the battle. Second thing, if there is a problematic collection, because one semen sample is not the parameter for you to judge the androgenicity. 3 samples have to be collected with a gap of 15 days and an abstinence of 3 days. So we come to a level, a graph. Okay, then what we do in the sperm tests, we do a survival test, we do a trial wash, we do the morphology, and we do certain basic simple like HOS test, etc., etc. And at the same time, the female undergoes the investigation on the other side of the coin. Her cycle time, her what we call it as a luteal phase, the bleed pattern, the heavy bleed, less bleed, sometimes there is dysfunctional uterine bleeding. And tomorrow when the female will discuss the basic investigations like the hysterosalpingography, the opening of the tubes, other infections, etc., etc., need to be investigated. So the first thing is everything being normal, just some tablets just to improvise the quality of the egg and to pep up the seminal quality, plus the trauma will be less on the patient. Oh, chalo, hamari dawa chal rahi hai. If you tell them you are perfectly all right and you don't give them a treatment, they will further go back deject because something must be drastically wrong, or that's why they are not giving us a tablet. So it is all the mind play over here. But most important, what we check today is the age. Today, 95% of the couples come to us for consultation post 36, 37 years, where the egg quality has dipped to abysmal level, because post 35, the egg quality drops down drastically. There is total aneuploidy of the eggs, dislocation of the chromosomes, no good formation of embryos, no implantation potential. Plus the lady is compounded by other problems, her obesity, her functionality of the tubes, receptivity of the uterus. The list is huge and endless. Yeah, next one.
Thank you, doctor. We have the next question by Dr. Borkar. Dr. Borkar asks, is rising infertility a trade-off for our Maltesian demography, sorry.
Can you just repeat it, Dr. Borkar? As usual, a very complicated question.
Read the whole question, Andrea.
Yes, sir. Is rising infertility a
Yes.
trade-off for our Malthusian demography?
Difficult to answer. Difficult to answer. Because sometimes at some places, unfortunately, we should not bring this as an excuse. You got my point. Sometimes at some places, even in the very much educated white-collared people, they are considering themselves infertile and childless, though they have got 2 daughters, but simply because they don't have a son, they are treating themselves as infertile. That's the sad part of the society. So we don't know unless and until you don't know the proper statistics, we are not able to come to any conclusion. That's the sad part. So I think it will be very difficult for me to answer.
Thank you, doctor. We have one more question from Dr. Borkar. Dr. Borkar asks, do women with primary amenorrhea conceive after ART interventions?
That depends to what extent it is, and to depends upon the age and to how much can they retry back to normalcy. So uske liye kya hai ki what you need is a thorough investigation and a proper history taking. Proper history taking, proper internal anatomical findings, and I would say peripheral hormone levels. Now let's say I say a person has got 30 million count sperm, but he is still not fertilizing, but nobody has monitored him for diabetes. Suddenly you find him diabetes is sky high, so obviously the answer is there. Similarly, in case of females also, and in females, the stress hormone cortisol plays the biggest important part.
Andrea, I think a delegate has raised hand. Can you please take that
Yes,
question?
sir. So we have some Mishra, Sakailash Mishra, he has raised his hand.
मिश्रा जी आप पूछेगा, मिश्रा जी आप पूछेगा. Professor Mishra, are you there? Karen, go on with, Andrea, go on.
Yes, sir.
Yeah, Karen, so I would just tell you that this is not basically actually the charm of embryology. The basic embryology charm is that once you finish with the male and the female part, then the actual process as far as then the culturing, then the gadgetry, then the QA QC, they form a complete challenging interactive part of the whole procedure. Because you have excellent couple, you have got excellent doctors, but you don't have a good lab to function upon. So what is the logic behind all that? Because what we want to do in embryology is to mimic the conditions in vivo and vitro conditions should be the same. Now you cannot make it the same, but in some cases they can be better than the in vivo. Why? Because the lady was having a problem. So that is the reason which necessitated the question of surrogacy. Now what is surrogacy? It's a womb born higher. But then you know the scenario which is there boomed up. Unfortunately, I don't want to comment onto it. But this is where we have to actually make our what you can say thinking very sharp and clear. So consultation and counseling. Today, nobody is counseling properly. Everybody actually counseling is to be done by an independent counselor, irrespective of the clinic. Now, many clinics have their own in-house counselors. Unfortunately, you counsel them to their own advantage. A counseling session is good when out of 10 people you counsel, 3 just walk out. because you have told them the real thing. You got my point. So it's not just like dangling the carrot in front of a horse, automatically they'll come grasping for it. Because remember, the same person, and in embryology, remember one thing, whenever you counsel or talk to a patient, never take an instant yes or no from across the table. Give them time to think about it. Many times it happens, they say, okay, yes, doctor, apun kara denge. After going home, you'll get a phone call, nahi, doctor, nahi karane ka hai. So give them a time to think, because they are so emotionally stressed out. In that urge, they will just say yes to anything you say.
I think there are more questions.
Yes, sir. We have Riddhi. Riddhi says a recent article stated that the tail of the sperm beats asymmetrically on one side while the head portion rotates along the same axis, allowing it to move forward. Is it the same as yawing motion?
No, yawing is different. Now, whenever a sperm locomotes, as I told you, the locomotion will also be dependent upon the placement of the organs. Now, suppose if this is the head and the tail is exactly in the center located, or the midpiece rather, that is axial arrangement, the sperm will go straight. But if a tail is placed over here and the sperm locomotes, the sperm will go in a rotating direction. So locomotion and the pattern of locomotion are two different things. Ideally, any flagella or cilia, when it propels, it has got two strokes, effective stroke and the recovery stroke. Okay. Now, in case of sperm, basic idea is that it has to propel forward. Now, you'll be surprised, many of the sperm propel back in the reverse direction also. That is a mystery which is still to be solved. How can they just keep on rotating back? So otherwise, these are all such small things which will keep on coming, but at the base of the mind, we need to investigate, or we need to be sure or ensure ourselves that if I want to do an IUI procedure or an IVF procedure or a high intracervical insemination, I should be ensured that the percentage motility is at least 70 to 80% with at least 5 to 10% of good active linear sperm. Bingo, that's it. Because the more and more we'll be drawn into this theoretical aspect, we'll be forgetting the actual procedure method. That is what a good working clinical embryologist should try to achieve. Otherwise, the list is endless. This type of movement, this type of yawing, this angulation velocity. You had seen the number of velocities which I showed you on the CASA. To be very frank, half of them which I still don't realize, I don't even recollect today. Actually, what do they mean by telling this? Remember, at times it's the man behind the gadget, howsoever expensive the gadget may be.
Thank you, doctor.
Yeah.
We have a question by Dr. Borkar. Dr. Borkar asks, can smoking and alcohol be a cause of male infertility?
Smoking, yes. Alcohol ka abhi tak research paper aaya nahi hai barabar. But smoking is what it is, nicotine contamination. And nicotine saturation in the blood or wherever in the body level, it compromises the ciliary moment. So what that is what we call it as nicotine-induced motility reduction. So you tell a person to refrain from smoking for 4 or 5 months, believe me, motility is improved because the ciliary network, the fibrillar network, the 8+2, and the mitochondrial potential to generate the ATP will be enhanced. So smokers, abstain from smoker, 2 to 3 months empirical therapy, vitamin E plus vitamin C, plus the psychology which the gentleman will have, plays a trick.
Thank you.
Thank you, doctor. We have a question from Vaishnavi Naik. Vaishnavi asks, can genetically acquired male infertility be treated?
Yes. Now, in genetics, usually there is a Y deletion of the chromosome. Now, if a person has a Y deletion and he does the ICSI by transferring his sperm into the oocyte and thereby subsequently fathering a child, the child is ensured of infertility, that's for sure. But they say, okay, if that child's sperm before the age of say 17 are collected and stored, the percentage of that damage in the pre-collected sperm will be quite less. But that is all still a hypothetical thinking. In fact, Y deletion problems are definitely subsequently reflected in the next generation. So that's the reason today many of the labs insist that you do at least a basic chromosomal mapping to help us find out a reason why this is, because it is our duty to tell the couple that the child, if it is a son, may be infertile.
Thank you, doctor. We have here a question by Persis. Persis asks, what could be the effect on sperm when a person could have a history of pituitary adenoma?
Pituitary adenoma, mostly it deals with hyperprolactinemia, because there is a swelling or a tumor in the pituitary, and this will cause, so when number of hormones are estimated and one hormone shows a high quantum jump over its normal level, so at that time there are certain drugs which will suppress the pituitary level. So because its pituitary is bound in a tight socket, the sella turcica. Okay, so whenever a tumor grows in, it has got no chance to move out. So it will just compress the cells inside. Okay, so one part of the cell will be, or I can say one gonadotroph. One gonadotroph will be hyper functioning. So we have to find out exactly what is the cause. Now, if a male has typical feminine characteristics, breast development or less facial hair, a typical female-like figure, and when he is detected for prolactin, gynecomastic. So according to that, now this is the role of a reproductive endocrinologist to take care of.
Thank you, doctor. We have a question by Tanvi Kamath. Tanvi Kamath says, it is known that exposure to some mutagenic agents or radiation causes mutations in the ovary in females. Does it also affect the sperm quality and quantity?
Yes, it does. Because radiation, that's the reason many a times, even when you go for a simple X-ray or your, what you say, lower abdominal part, you are actually advised to protect your genitals with some lead-bound covering or the sheathing, so as to they become less traumatic. Or if a person is suffering from cancer and he has to undergo radiation therapy, what we do is we preserve the sperm and the eggs in advance. Now, egg preservation has caught up the world now since last 4 or 5 years. But prior, sperm cryopreservation, this is where exactly the onset of cryopreservation had started. Cryopreservation of sperm, especially in cancer treatment, where high rads of radiation will make the germinal epithelium redundant. So when that time we used to do testicular biopsy and we used to see the testicular score, it was from 0 to 10. 0 means just the germinal epithelium, and 10 was a fully matured functioning spermatogonia. I mean, the seminiferous tubule. The rest were in between. Arrested spermatid stage, arrested spermatogonia stage. Now it depends upon what extent. So when you are seeing there are 2 spermatogonia A and spermatogonia B in the basal level, one is always dormant and the other is always active. But in case of the other one suddenly being inactive, the other one used to spring up into dormancy. But when the rads of the radiation dose was high, it was a permanent damage, unfortunately, which is non-reversible.
Thank you, doctor.
Thank you, doctor. I think, Andrea, the questions are done.
Yes, Karen.
Yeah. So thank you, Andrea, as well. And thank you for the participants. I would like to inform the participants that the Zoom link for tomorrow will be sent to your respective emails. And on the last day, that is on Tuesday, we will also be giving you the feedback form, the link to the feedback form, through which you can give us your feedback and also get your certificate generated. So thank you once again, Dr. Avari, for your amazing session and answering so many questions that our participants had. And thank you to the participants for your listening and for asking so many questions. Good night to all of you, and we shall see you all tomorrow. Thank you, everybody.
Yeah, just one. I would just request, was my pattern of delivering quite okay by you? You want me to go slow? You want me to go fast? Was the take-home message conveyed to you?
Very optimal, very optimal.
Yes,
I think it's very optimal. Very optimal.
But as I told you, this
Because
is
the audience is a mixed lot of
yes,
undergrads,
exactly.
postgrads,
Absolutely.
and
So I just try to
we
keep,
also have some from the medical fraternity.
I
So
agree.
think that's
I agree.
a tightrope walk. You
yes,
need
I
to-
agree, because certain things I try to keep to as much as basics, because let me be very frank. Today, these simple basics of that type of collection, how to evaluate from the volume and the pH, this all goes unnoticed. And you
Absolutely.
don't realize how much important a yardstick it is to measure the androgenicity.
Very true. Very
That's
true.
the sad part.
So
Chalo,
it's
anyway,
perfect. Absolutely.
good, fine. So
Thank
we'll
you.
meet tomorrow at the same time,
Yeah.
same panel. Okay.
Yes.
Thanks a lot.
Fine.
Thanks a lot.
Thank you,
everyone.
Tomorrow's
Good
is
night.
for,
Stay safe.
tomorrow is female
Thank you.
infertility. Female infertility,
Yes.
right?
Thank you
Yes.
so much.
Chalo. Thank you. Good night. Bye-bye.
Thank you, everyone. We shall meet again tomorrow at the same time, that is 3 p.m. The link will be sent to you on your registered email ID. Have a good evening, everybody.